Hello and good morning, everyone. I'm happy and it's an honor to present this webinar today with the Sagalign Academy from 3D Master. And today we are going to talk about 1 hour about the modifications and accessories in aligners. Since aligner is a very fastly expanding contemporary treatment, and with my experience with these types of appliance, I faced sometimes problems. I'm going to share my experience, how I'm going to overcome these problems. So the treatment with aligners would be more applicable and more predictable. I'm Professor Omar Fawzi Chawshli. I'm a consultant orthodontist. This webinar and presentation is organized, thankfully, by 3D Masters, Sagalign Aligner, Clear Aligner. And this is my Instagram page. If you like to follow and to have any inquiries or questions later on, I will be ready. My last scientific activities, was as a speaker in Romania, representing my country in is everything clear? Can you hear me? Can I have a response? Please inform me if there is any lagging or any problem with the presentation or with the voice. Okay, so the presentation is clear. This is the most important. If the presentation is clear, that's okay. My photo is not that an important issue. Okay, so I will continue. As I said, my last activity was as a speaker in Romania, where I present my lecture in a large crowd of orthodontists worldwide, where I represented my country, and we had a lot of positive feedback there on the presentation. So I'm going to start the presentation, and I hopefully attempt to cover everything in 1 hour. Aligner orthodontics or aligner treatments is, as I said, is very widely expanding and fastly expanding treatment, but it is like any other appliances. It's an appliance, it's a tool. Always we depend on the science, on our knowledge with orthodontics to treat cases, but it is a very nice tool, a very demanding tool, but for sure, for whom that is going to start, they will have some problems. And the main issue and the problem that will make you frustrated or annoyed at the beginning with the start of the aligner treatment is the loss of tracking. Loss of tracking means when you give the aligners to the patient and follow the treatment, as you see in this video, sometimes in a specific number of aligners, usually maybe in the after 4 or 5 aligner, or at the middle of the treatment, you will see that the aligner or the tray is not fitting anymore. And that one of teeth are out of the movement sequence, not with other teeth. And this is called loss of tracking. Why it's happened? There is many reasons for loss of tracking. Compliance is the main issue, because we need at least 22 hours of wearing of the appliance, and this is a very important thing. That's why you need to discuss this with your patient before you start your treatment. Otherwise, you will not have successful results and you will have failures with aligners. Second important thing is predictability. What we mean by this? Predictability of the movement. If you look to this diagram, this is evidence-based classification. You can see we have 80% or close to 90% predictability with distalization with aligners. Then it's coming down with expansion, buccolingual tip, rotation, lastly extrusion. So if you have movements like severe extrusion, for sure you will have loss of tracking, and you need some modification or accessories to improve your outcome with aligners. Then staging. What we mean by staging, the sequence and the stage of the movement, like as you see in this diagram. In the first upper photo, you can see a sequence of distalization of the molars is a sequential distalization. What I mean by this, there is distalization of the 7 first, then after a number of aligners, as you see here, you can see start of the distalization of the 6, then distalization of the 5. And this is correct way. Why? Because we want to divide the movement in order to avoid loss of anchorage. If you didn't follow this sequence in your treatment planning, of course, you will face some problems. Also, the mechanics and the sequencing. If you have a fault and problem with mechanics or sequencing, you will have loss of tracking. Like, it's not logic to do expansion with protrusion of the anterior teeth. There are two movements which are against each other. Constriction and retraction of the anterior teeth. They are two movements against each other, so they are canceling each other because they will take anchorage from each other and they will cancel the movement. So avoid movements like this. Extrusion of both posterior and anterior. If you have posterior extrusion against anterior intrusion, this is good. Or anterior extrusion against posterior intrusion, this is good. But if you have overall extrusion, this is not logic. Or overall intrusion, also this is not logic. This will lead to loss of tracking and the teeth will not follow the tray. Or if you have a severe palatal root torque and at the same time I have a distalization, I get anchorage for distalization from anterior teeth. So if I'm moving the teeth at the same time I'm making torque, this will jeopardize the anchorage value for the distalization of the molars. An important thing is single teeth movement like derotation and extrusion. One mistake many designers do is when they try to extrude a tooth and derotate it at the same time. In fact, derotation requires an intrusion movement in order for the plastic to catch the tooth and make the derotation. So when you receive a treatment plan, you need to check these in order to avoid loss of tracking. Otherwise, if you had a loss of tracking, you need, which is the subject of our webinar today, to use accessories and modification, elastics, button, power arms, TADs. Sometimes it's not the fault of the design, not fault of the sequencing, not fault of the patient, but the movement necessitates that. The logic and the mechanics necessitate placement of a TAD. The anchorage necessitates placement of a TAD. So sometimes we will have like problems as you see here. This central incisor is under erupted regarding other teeth. Extrusion of the lower anterior is somewhat very difficult. So adding accessories like this, like as you see, small stopper tubes with a piece of nickel titanium wire will enhance the predictability with aligners. Or we use TADs a lot during intrusion because you know with aligners, with the thickness of the aligners, yes, intrusion, posterior intrusion is much predictable than fixed appliance in posterior intrusion, but to a limited level, 1 millimeter, maximum 1.5. If I need more intrusion, I will need to insert TAD. I will need to insert TAD palatally and buccally, and I will show you that. As you see here, we do a posterior intrusion for the treatment of an open bite with aligner. Extruding the anterior teeth with aligner to close a bite, it's almost an impossible or very difficult procedure. But the result would be very predictable and very easy to manage if I do posterior intrusion. And by the way, this is more stable because my mastication and occlusion later on would be my retainer for the posterior intrusion. While if I did anterior intrusion, I will face relapse later on. And if you, as you see here, we apply a TAD palatally and a TAD buccally, and we ask the patient to pass an elastic, an intraoral elastic from the buccal TAD to the palatal TAD over the aligner. This will enhance the intrusion. And by the way, intrusion in this way is much controlled and predictable than fixed appliance. Because with fixed appliance, we are applying the force buccally and palatally in 2 levels, and we are away from the center of the resistance of the molar, which is in the center from the occlusal view. So the force is not from the occlusion, it's from the buccal and the lingual side. So there will be always some flaring, some constriction. It's not that controlled. We need a lot of modification in the wire torque control, but with aligners, the plastic is holding the two teeth together, and the elastic will ensure a force application from the occlusal point of view. And this means the force will go directly to the center of the resistance from the occlusal view to the molars and premolars, and this is good. Also, we can do whole arch intrusion in gummy smile cases, as you see, intrusion in the anterior part and intrusion in the posterior part. In the anterior part, we don't need tats. We just attach the elastic to cuts in the palatal border of the aligner, and we pass the, I will show you this later, the elastic to the buccal surface. Or we use, like when we have uprightening of the molar, this is also a difficult movement for the molar. We use tats in order to insert a segmented arch wire. I will insert a molar uprightening spring. This is a classical old design wire, but it is very effective. We use a 17 by 25 TMA wire and a small tube bonded to the molar. I will cut from the plastic to make a room for the tube, and I will bend the wire, as you see, very easily, and I will seat it on a tad, which is inserted between 4 and 5, ligated with ligature wire, or place a flowable in order to avoid poking of the patient cheek and gum. And this wire will upright the molar for me, and it will follow the movement of the aligner, the sequence of the aligner. We can use also the ready-made molar uprightening springs. This is from Dentaro. They are a combination of steel and night-tie wires. The anterior part is night-tie, the posterior part is steel. They are ready-made from Dentaro, or we can simply just attach brackets and place wire in order to upright the molar. And we make, as you see, we have a player to make cut in the plastic in order to make room for the tubes and the brackets also. Also, we can do some like uprightening of the root or retraction to close the extraction space with adding accessories. As you see, tubes, uprightening springs, power arms. As you see in the photo in the right, we have two power arms, one from molar and one from the canine, which will help to make the force of retraction close to the center of the resistance, the level of the center of the resistance. This will ensure that the canine will be retracted in more root responsive way, in more bodily way. It will not be 100% bodily, but it at least would be a controlled tipping movement, and it will help in uprightening of the root of the canine. And at the same time, I will follow this movement in the software. I will add the movement and enhance the predictability with adding power arms. Of course, we can use tads with elastic to make retractions, IGC tads, buccal shelf tads. We will show you all of these. So what is the modifications and accessories I usually use? Interarch elastics. I use elastics a lot with aligners, help me to correct sagittal problems, vertical problems. Tads, very useful to enhance the anchorage. Intrusion and extrusion done with accessories. So regarding interarch elastics, we can use cross elastics, as you see here. We need players to make cut, and we need buttons to be attached to the lingual surface, palatal surface of the upper, buccal surface of the lower. And as you see here in this video, the way that I cut from the plastic in order to make room for buttons, and the buttons will be either a metal buttons added to the lingual palatal surface of the upper and buccal surface of the lower, and the elastic pass from the lingual button from the palatal to the buccal button in the lower, or I'm going to make composite buttons, or I'm going to place ceramic buttons. We have ceramic buttons which is available, okay? So also class 2 elastic could be placed from buttons which is made from composite, and I made this composite buttons very easily. As you see here, this is a demonstration. You will apply bonding to the tooth, and you cut with the player to make room for the button. I simply use a separator elastic. I make a cut in the separator elastic with a scissor in order so I can remove it easily. Then I will cure the bonding. Later on, you are going to use some flowable composite to be fill the lumen of the separator to make the neck or the stalk of the button. Then you overflow the composite over the separator to make the head, the ball of the button. And once you cure it, you are going to remove the separator very easily because you cut the separator at the first place before you start. Once you remove the separator, the button is there, and this is very easily. Of course, it's aesthetic for the patient, and this is very important because our patients seeking aligner treatment because of aesthetics. Now the button is there, and the patient can attach elastics. Or we can make cut in the aligner, and I will show you players. Previously, we used to make cuts with bears, and as you see here, the cut with the bear would be somewhat messy, irregular, but now we use players, and the players help us a lot. As you see, this is called a punch cut player, punch hole cut player, which make hole in the button area in the molar side. And also this is called teardrop or precision cut, which will make a cut in the canine area or anterior area in order to attach an elastic. And this is very important. Space closure, we place power arms, ready-made power arms. We have ceramic and metal. We bonded with composite, and also we need to make cut in the aligner with the punch hole cutter. Single tooth extrusion. One of the problems that we always face is extrusion of small teeth, especially the upper lateral incisor, and it happens with the lower incisors too. Why? Because as I told you, the less predictable movement is extrusion. And the most problematic extrusion tooth is the lateral because they have short crown, small surface area that the plastic cover, and even adding the attachment will not be that helpful. So when you see, as you see here, when you see a lateral losing the track from the aligner, we can add buttons and cut from the aligner and add elastics on the aligner. So this elastic will extrude the lateral for me into the housing of the aligner to retract the movement, okay? And this is an illustration of how we do it. And you can see lingually how I attach the elastic to the aligner. I make 2 teardrop cuts with my player, of course, or you can do it with the bear. As you see, these 2 cuts will make the elastic placement very easily, engaging the elastic to the aligner. And once the patient wear the aligner, will pass the elastic from the aligner to the button that I made with composite on the cervical area of the lateral. This will enhance its extrusion and returning into the housing of the tooth. Also, we use this technique to make intrusion in the anterior teeth by placing tabs and making precision cuts. As you see, we made a punch hole cut in the cervical area and 2 precision cuts in the palatal area. Then we place a button and we place the elastic, and the patient will pass the elastic in order to extrude it in order to make the movement predictable, okay? So we use this technique also for intrusion of the incisors. How? We make the precision cut palatally and place 2 tads in the incisor area. As you see here, the tad is between the central and lateral, which is not preferable, by the way. I will show you. We prefer to place the tads anteriorly, which is the most safe area, between the lateral and the canine. Or, which I prefer more, I place it distal to the canine because I will have a distal element force to avoid the flaring with intrusion. And as you see here, this is a total intrusion of the maxillary arch for the treatment of gummy smile, and you will see gum smile case later on, if we have time, hopefully, where I inserted 2 tads anteriorly, precision cuts in the palate to catch or to hold the elastics, and 2 tads palatally with 2 tads buccally to ensure the intrusion. Hopefully the slides are clear and you can hear me. Otherwise, you can give me a signal that there is a problem, so I'll stop. So I'm going to continue. Now, how to use the Sagalign intrusion tads. This is an animation again, how we are going to make the cuts and how to attach the elastics. You can use this videos to motivate the patient or to learn the patient how you are going to use the elastics. and the elastic will place in the cuts, and the elastics will be attached to the tats. Okay, so good, everything is clear. Now, we can use it also for only posterior teeth. When we have open bite, it's not a must to use it only in gummy smile. When we have open bite, we use a posterior intrusion, TADS palatally and TADS buccally. Or if your patient is not preferring palatal TAD, or they are sensitive with placing TADs palatally because it sometimes annoys the tongue, it is in the area where the tongue is moving, mastication, you can make these cuts that we made in the anterior region in the posterior region and attach the elastic. Again, this would be helpful. Sometimes, as I showed you, we need uprightening of the molar, so we use uprightening springs like this, uprightening springs for the uprightening of the canine. And as you see, this is the active form of the wire. This is the passive. I use segmented wires a lot with the elastics. Now, let me show you a summary about the elastic, class 1, class 2 elastics. This is how we use class 1 elastics. We made a cut. For example, if I have a class 2 and I want whole maxillary distalization, we can do it with aligner. We can do semi-sequential distalization with high percents like 50% or 75%, but be careful. This will increase the number of the aligners a lot. You may reach to 60, 70 aligners, and this is increasing the cost of the aligner treatment on the orthodontist and on the patient. But if you use TADs, like IZC TADs, with elastics, we can reduce the number of the aligners by depending on TADs to make the distalization, and the patient will wear the elastic from the aligner number 1, make the precision cut or the teardrop cut from the first aligner till the end of the treatment. The alignment and leveling procedure will continue with the distalization, okay? How we are going to use the elastics? Again, we are going to make the cuts, the precision cuts in the canine area in this way, which is directed anteriorly, so the elastic would be catch the aligner, and the patient will place the elastic on the TADs. Class 2 elastic, the same thing. You can make the cuts in the canine area and a cut in the molar area, whether you are doing precision cut or you are doing a punch hole cut and placing a button, which I prefer, placing button on the molar area to not dislodge the appliance, the lower aligner, and place a precision cut in the upper to attach the elastic, and the patient will place the elastic from the precision cut to the button which is placed on the molar in the lower arch. Class 3 elastic, the same thing, which is the opposite of class 2. Sometimes we use combined elastics, like it is a severe class 2. So during the planning of the treatment, we plan to use class 2 elastic, and to enhance that and to increase the predictability, we add 2 TADs, IZC TADs, and add a class 1 elastic. So the class 1 elastic with the TAD for distalization added with the class 2 elastic, this will increase the percentage of distalization. Cross elastic, you've seen that, how we are going to place it. Players that I show you, really we have a lot of players like teardrop players, button cut or punch hole cut player. We have horizontal box, vertical box. As you see here from this photo, we have many types of aligners. But for me, for every orthodontist, which is practicing aligner, you need at least 2 players. At least you need this player. You need the teardrop cut player, which is available and it's affordable. You make cuts, teardrop cuts or precision cuts when you want. Of course, you can ask that from the Sagalign lab to make the cut for you, and they will bring the aligner for you. With the cuts are there. If you're planning that from the beginning, planning to place that, planning to place class 2 elastics, they will bring the aligner with you already with the cuts, with the precision cut for the canine and with the punch hole cut for the molar, so you will not bother yourself with making cuts and taking time during insertion of the aligner. But sometimes you may make modification or change the plan at the middle of the treatment. So you need this player to make the cut by yourself. And this is how the cut it would be after you make the cut in the canine area. And the second one, button player or punch hole cut player, this is also a must because I use this to remove a part to make room for buttons, to make room for bone double tubes, buccal tubes, to make room for stoppers to insert wire, or power arm. I want to place a power arm. I need this player to make cut to make the room. And as you see here in this photo, we placed two buttons, one in the canine, one in the molar, and we made room for these buttons by making punch hole cut with this player. Now, TADS. TADS is very important to use with aligners because like other appliances, like fixed appliances, anchorage is a very important point to consider. And TADS make our life easier. TADS make our results more predictable. The TADS that I use a lot with aligner is IZC or infrazygomatic crest, buccal shelf for the lower, buccal implants in the upper and lower, like anterior incisor, posterior, upper and lower, or I use palatal incisor. TADS. IZC TADS or infrazygomatic TADS, usually we need stainless steel TADS because it is a very strong bone, so it will broken if I use titanium. We use 12 or 14 length because I need to reach to that anatomy. When you look at OPG, you need to find the zygomatic process, and once you find the zygoma, the infrazygomatic process is immediately beneath it. Sometimes when you insert the screw, you will get inside the sinus, and this is not an issue, by the way. This is evidence-based, and many articles published. An article published by Chris Chang, who intentionally placed IZCs inside the sinus. There was no any, as a conclusion, no any side effect, no any problems, no any failures. So it's not an issue. We use 2 millimeter and long neck. Long neck is very important because this is placed in an area of movable mucosa, and to avoid failure and inflammation, we need to have a long neck. So this is the anatomy, exactly below the zygoma between the 6 and the 7. And look to the animation, which is from Chris Chang. And this is the video where I clinically show you how you are going to place IZC. The key point is first to make an indentation in the bone to avoid slippage. Then the most important key point is to place the implant perpendicular to the bone first. This means I will not make it vertical, I will make it horizontal as you see. And once I engage the bone, 2 to 3 flutes or serrations of the screw, then as you notice, I make my hand vertical in order to go up into the zygomatic process behind the cortical bone to end up with the screw 70 degree or 80 degree angulation. This will ensure my screw will be in a hard cortical bone out of the roots to allow for the roots to be distalized. Okay? And as you see after the screw placement in the OPG, you can see on the right, it's slightly tilted. On the left, it's more applied, but almost in the left, I penetrated the sinus, or at least I engaged the sinus wall, and this is not an issue. Buccal shelf implant, it is the opposite of this implant in the lower. So I use the buccal shelf for upper distalization, the IZC for upper distalization, while I use the buccal shelf for lower distalization. And we place this in this, as you see, the red dot, in the this anatomical landmark, which is the buccal shelf bone. Many patients, they have this bone, but others, they do not have it. So you don't have this buccal shelf, you cannot place the buccal shelf. You need to palpate it, you need to take x-rays to be sure you have this bone. Again, the key is what? To make a scratch and to go vertical to the bone. This is mean horizontal first, then turn your hand. Otherwise, you will have slippage, trauma, injury. Usually, the length is not more than 12 millimeter, 2 millimeter width. Again, it should be stainless steel because this is a very hard bone and it needs a lot of torque for their placement. This is the anatomical landmark. And when I insert the screw, they are vertical about 80 degree with the teeth and they are out from the path of the movement of the root. So the root will move very easily distally. As you see again, the animation from Chris Chang and the video clinically from my clinic, you can see I made the scratch, and I intentionally showing the left side because the left side is more difficult than the right side. You need to come to the left of the patient, move the spit in a little bit and make room for yourself because it's difficult to apply it from the right side. Anyhow, I went vertical with my hand horizontal, then I make my hand vertical. And usually the patient will be annoyed because you are applying a lot of pressure, but it's very important, as you see, to place your fingers beneath the mandible to support the mandible because you are applying a very high force to insert this screw. This screw is very strong screw, will have good stability, good amount of resistance to distalize the teeth during retraction of the anterior teeth, especially when you have crowding in the lower anterior teeth. To avoid extraction, we can do distalization from canine and distal, and at the end, the screw would be vertical with the long axis of the teeth, okay? Also, we use interradicular screw, buccal screws for the intrusion of the posterior teeth in conjugation with the palatal one. Just I will make an engagement. And the key here in this screws is to insert it in the attached gingiva. It's not like IZC and like buccal shelf because these screws has a long neck. It's okay to be inserted in the movable mucosa. As you see, I have a good stability. I remove my hand to show the stability, so I have a good bone. But the key here, I have short neck, so I need to be inserted in attached gingiva. I will never pass up to the movable mucosa. My screw is usually 8 millimeter, 1.5 in diameter, and it's titanium screw. And I use area between molars or between molar and premolar. So the screw would be inserted between the 5 and 6 or between 6 and 7. This is very good area, and you can the amount of the stability. And to know that your screw is successful, you need to have a good torque during insertion, good stability at the end because it's a mechanical locking, it's not osseointegration like prosthetic implants, and you need to have at least very limited amount of bleeding. If you have a lot of bleeding, this means your screw will fail. Now we need to place a TAT in the plate, and I'm showing you how we are going to place that in the plate manually. Placing TATs in the plate is much easier because all the plate is attached gingiva, and I use screws 8 millimeter again length, 1.5 diameter, titanium screw. And the insertion is easy because you are inserting between two roots and the distance is far, not like the buccal. For the buccal, for the molar, we have two roots, but for the palatal, we have one root. So distance between them is high. The only problem here is the greater palatine artery. The greater palatine artery is there, but it is about 11 millimeter to 12 millimeter from the cemento-enamel junction. So keep your screw usually 10 millimeter, no more, from the cemento-enamel junction. This would be in a safe area. Even accidentally, sometimes we have variation. You touch the greater palatine artery. It is not a huge medical problem. You can remove your screw and make pressure till the bleeding will stop. You may need a couple of minutes and the bleeding will stop, and you need to follow up and reassure the patient, okay? Again, I'm showing you how I'm going to insert TAD in the palate, but I'm using the handpiece, a manual handpiece, which is also available commercially. Here, it is much easier to place it. Why? Because I don't want the long shaft to insert it. I use the angle handpiece. There is the motorized one, and this is the manual one. In the manual one, you can feel the torque, and you can feel the tactile sensation. This will make the insertion more comfortable to the patient. I'm not stretching the lip and the cheek a lot, and it's more comfortable for me too, because I'm not trying to make my hand straight by pushing the teeth and pushing the lip, okay? So with the angle handpiece, you can insert it very easily between the roots of the, of course, 5 and 6. Sometimes we need to place it between 6 and 7, but the safest area is to place between 5 and 6 palatally 10 millimeter less, like 8 millimeter or 9 millimeter from the cemento enamel junction. This would be a safe placement and stable placement of the TAD, and we use that for the intrusion. Okay. Now, with the time we had, I hope we can cover some clinical cases where we applied some accessories and TADs. This case came for the treatment, and she specifically asked for aligner treatment. As you see, I have a shift in the midline. I have a crowding, severe crowding in the lower, and also I have a class 2 relation on the left side and a class 1 relation on the right side. And this is a problem because we need to correct the class 2 relation. You can see we did some contouring and reshaping and composite for the teeth. We call it hard tissue contouring. If you have broken teeth, I would like to restore it with composite before aligner, because the mechanic of aligner depends on the surface area of the plastic coverage by covering the teeth. So as much as surface area I have, it would be better. So restore the teeth before aligner, before scan. As you see from the occlusal view, from the lingual view, I have a very severe crowding in the lower anterior. Even it's difficult to be treated with fix without extraction. Now, this was the clinical setup, and you are going to check the movements, the mechanics, in order to avoid loss of tracking. And we started with the aligners. As you see here, I have a class 2 elastics, and here I need to place an accessory. I need to place a button, I need to place an elastic, because distalization with aligner, yes, it's very predictable, and it's the most successful movement to be done with aligners. But I will need a long duration and a lot of aligners. To avoid that, I can augment this, or I can do the half of the distalization process with aligner, and half I will depend on elastics. Okay, so after a while we have improvement. We re-scanned for refinement, and we have another set for aligners. As you see, attachment in place, improvement in the class 2. As you see in the left side view, I have better relation now for the canine. Now we have a good alignment of the upper teeth. Alignment in the lower teeth is just perfect compared with the previous situation. Then again, I will add more cut in the aligner with my punch hole and with my teardrop, and place class 2 elastic again. Why? Because I want to make the class 1 canine perfect class 1 canine relation, and also I like to make an over treatment because of the relapse. So you can see how the elastic is placed. You inform the patient to place elastic in the aligner, and the patient will wear the aligner. Then you make cut, and if you see on the left side, this is a mirror view. You can see the button. And now I have much better smile. The midline is very nice now. I have a good correction of the midline thanks to the class 2 elastics, for sure. We did that with the accessory, with the modification with class 2 elastics. And I have even more improvement, as you see here. Then the alignment is perfect for the upper and the lower. There is improvement. This is the case. As you see here, I have a problem with this central, and this is not a problem of the aligner. This is a problem, as you see in the photo from the left side. There's an attrition and broken, and we would better to treat that with composite. We try to grind the tooth to make it flat. This made the tooth shorter. If I treat the case, I will add composite, will not grind the tooth. Anyhow, because we grind it, it's shorter from the other, and extrusion is difficult. So we made cuts, punch cuts in the aligner, and added tubes in order to extrude that part, and we extrude it into the level of the other teeth. You can see class 2 there still, and there is better improvement of the central now for the upper and for the lower. Almost finished. We finished the case. We have a perfect midline, perfect class 1 on both sides, and good alignment of the teeth. And now as a retention, you can see class 1 canine relation, good alignment of the teeth of the upper. As a retention or stability, I will remove the attachments and inform the patient, or ask the patient to wear the final aligner, final number aligner. tweered 8 hours daily for 2 months to make stability. Then I will scan to make a retainer for the patient. You can see the final smile of the patient, very nice smile. She was very happy. We removed the attachments after 2 months and scanned for the aligner. You can see the alignment, the canine relation on both sides. The overjet is just perfect. The occlusal view of the upper and lower. And we have a very nice final smile. And she was very happy. It's a very comparable result with the fixed appliance, okay? Another case, this was a relapse case. She was treated by fixed appliance. And I like to use aligner for retreating cases for many reasons. Retreating cases, the patients are usually tired from fixed appliances, and this will motivate them to use the aligner more. And at the same time, the mechanics will help me to make like improvement of what happened due to fixed retainer or due to the mechanics of the fixed appliance. So as you see here, after the orthodontic treatment, there was relapse, the class 2 relation on the right side, the wire effect. This is called fixed retainer syndrome effect, where the fixed retainer is not a suitable wire for fixed retainer. They use multiflex wire, and this is not right. You need braided wire to use the fixed retainer. So there will be movement. We removed the fixed retainer. We made some hard tissue contouring composites added. We scanned, as you see. The main problem is with the extrusion of this canine and the class 2 subdivision, class 2 in this site. I will need to use and the rotation of this premolar and this canine. These are problems. I will need the use of class 2 elastics. So as you see in Sagalign lab, we made the treatment plan. Everything went good according to the treatment plan, but we discussed that with the lab, we will need a class 2 elastic on the right side. Otherwise, this movement will not be predictable. This is the report from the lab where we had phase 1, 15 aligners, phase 2, 6 aligners. So you can imagine 21 aligner. You can finish this case in a 10-month, and this is a very nice duration for treatment. That's why I like aligners for retreatment. They are fast. They are more acceptable by the patient. These aligners are from Sagalign, and you can see how they are fit, how their borders are extended, which I like. I like the extended border to the gum because this will give me good retention. This will give me good control of the movement of the teeth. So I always recommend extended border to the gum, at least 1 millimeter or 2 millimeters. Okay, as you see, we started from the first aligner with class 2 elastics. And this is a must, because if I didn't do that, the movement will not be predictable. And this is discussed with the patient, discussed with the Sagalign supplier lab. So we started the treatment. This is aligner number 1. After a while, we have improvement. We scanned for the phase 2. As you've seen that there was a phase 2 scanning. We have improvement in the canine. You can see it from now, the vertical control of the canine, the anterior teeth. I have a good relation. The canine is improved so much thanks to the class 2 elastics for sure. And we have good alignment. Now in the phase 2, we did another scan and some attachments is added, because that's why we need to make the treatment in phases, because you will plan something and you will plan the second phase. Yeah, but once you make the second scan, sometimes the movement is not exactly what you predicted. In this situation, you are going to re-establish a treatment plan and add some attachments, make some modification, and this is good, by the way. We did some improvement in the treatment plan and added some attachments. After the treatment plan is approved, you can see new attachments is added in order to control the midline, control the vertical position of the canine. And one important thing, we need attachment. When we use class 2 elastics, this is a very important point. When you use class 2 elastics, I need an attachment on the molar where I'm going to place class 2. This is passive attachment to make retention of the aligner. And at least I need an attachment on the canine or the tooth adjacent to the canine, which is 4 in this situation. Why? Because I need a passive attachment for the retention of the aligner. Otherwise, the elastic will dislodge the aligner. So always, when you are planning class 2 elastic, you need to place passive attachments on the molar and on the canine or the tooth adjacent to the canine, okay? Improvement in the rotation, improvement in the canine. We see the improvement and the sequence. The attachments are in a way that almost finished. We made almost a complete treatment with these 2 phases with 10 months, but we had another scan for some finer refinement. I think we added extra 2 or 3 aligners, and we finished the case. So this case is finished with less than 1 year. She was struggling with previously with fixed appliance. Now we have a perfect midline, a perfect alignment of the teeth, canine. We have a perfect class 1 canine on both sides. Look to the class 1 canine, how beautiful it is. Class 1 canine, class 1 molar. How I established this? Just with class 2 elastic and aligners. The patient was very happy because she wasn't annoyed by the brackets and wires. She was very cooperative, wearing the appliance 22 hours a day and using the elastics. And we had a very good compliance. You see the nice alignment. Look to the premolar. One of the difficult movements with aligners is derotation, and we treated this case with Sagalign aligners, okay? So you look to the upper, which is before, and to the lower, which is after, okay? We have another case, which is a relapse case, also a referral. This is a very nice appearing case. She was annoyed about the relapse for the class 2. As you see, we have half class 2. If you look to the alignment, there's slight spacing. And by the way, treating of the spacing is very easy with aligners, and it's very predictable because the treatment of spacing, if it is not too much, it's by control tipping. And one of the best movement to be done with aligners is control tipping. So as you see in the treatment plan, we closed the spaces. We treated the class 2 with class 2 aligners. So from the day 0, we added the attachment aligners, and you can see the extended border, which I like for the retention. You can see the attachment. Please notice the attachment on the molar and notice the attachment on the premolar adjacent to the canine. This is important during treatment planning. You need to discuss these things with the clinical approval, with Sagalign, with the lab when you are going to approve cases. So you need passive attachment to the canine or adjacent to the canine, passive attachment to the molar, button on the molar, precision cut, or they made the cut by themselves. So just I gave the aligner to the patient and elastics, and I had a very nice closure of the spaces in a very short time. It was like 6 months. So look to how they are very nicely uprighted. The spaces are closed. I have now class 1 canine, class 1 molar. It was a relapse case. So everything there, it was an easy case, but not for class 2, because if I was treating this with fixed appliance, I will need at least 1 year, 1.5 year, because I need to align the teeth. I need to distalize, whether with TADs or with class 2 elastics, but with aligners, we finish it with 6 months, closing the spaces, correction of the canine relation, okay? As I told you, what I like to treat always with aligners is spacing, especially if it is not too much. Spacing could be treated very nicely with control tipping with aligners. The challenge is, in this case, is this premolar. Is this left upper tooth number 24, because it's rotated and it's up in the occlusion. So I need derotation and extrusion. In this side, I don't have this problem, just the problem of spacing, some proclination. This rotation is a problem, and I was concerned about that during treatment planning. And as you see here, you will see in this case, we will lost tracking. It was my mistake because I didn't notice in the treatment plan, as if you look to the premolar, please, I will repeat the video. I want you to concentrate on the tooth number 25, on the treatment planning. You can see the premolar is rotating and extruding. And as I told you in the beginning, to not extrude and derotate at the same time. The mistake was we was in a hurry. So I want first to make derotation with intrusion. Derotation with intrusion to make the derotation predictable. The lab added the attachment. This is good point, but the movement was wrong. Then after the rotation, we need to make extrusion. So do not do both them together. As you see, two faces, but the faces are increased into three, I think to four, because we had problem with this tooth. So attachments is added, extended border aligners. Always keep this point in your mind. If you receive your aligners and your border of the aligners are shorter from the gum, return it back. Ask for extended aligners, borders. This is very important for retention and for controlled, predictable movement. Okay, I will go fast because we have shortage of time. Improvement, as you can see, I have no problem with the spacing. Here I have loss of tracking. And you can see the tooth number 24, there is loss of tracking. So here I'm going to use an accessory to track. First, I backtracked. What I mean by backtracking, I will ask the patient to go back with the aligner, like to go back 2 numbers or 3 numbers. But again, when we return to that number, there was loss of tracking. The movement was wrong. So we added buttons lingually and a power chain, and we made cut with the punch cut player, and we derotated the premolar with elastic with the aligner. I didn't stop the aligner. So we derotate it, and you can see the improvement with the aligner. Too much improvement for the spacing, improvement for the alignment, improvement for everything, but the derotation was an issue. So we added elastic. There is improvement in the derotation as you see here. Now, almost the derotation is corrected, almost finished. Now I'm making another scan for refinement, but as you see, I have a problem again with what? With extrusion. So always the problem with aligners is rotation and extrusion. For that, I added buttons by myself, but now you can ask the Sagalign to make hole for that before you make the scan. So I added the button and made the scan, and the premolar is totally corrected. As you see the buttons there, I received the final set of the aligners, and as you see the elastics is there. It's important to use these accessories to make the result. I will show you a gummy smile case where we treated with TADS. As you see, the problem here is shifting of the midline, gummy smile, hair shift complaint, class 2 on this side, class 1 on this side. We did some hard tissue contouring, composites, and we did the scan, treatment planning with Sagalign. I will go because I want to reach to the accessories. Yes, I started class 2 elastics to correct the class 2. And as you see on the left side, you can see the midline is corrected. The class 2 is corrected. Hair smile is much better. I have total class 1 on this side. Now I have the problem of gummy smile. So I'm going to scan for the refinement, and I will do impaction of the maxilla with 4 TADs, so 2 TADs inserted. These are 2 incisor TADs. As you see, I placed it between the between the lateral and the canine, and 2 TADs posteriorly between the 5 and the 6, and elastics pass from the inner side. This is how I placed elastic here with no palatal TADs. Cuts from the palate to the TADs buccally. You can see teardrop cuts from the lingual side to the TADs palate on the buccal. And for the molars, the same thing. Cuts from the lingual surface. And we continued with intrusion. You can see I have a successful intrusion. And we did some soft tissue contouring. Look to her, very nice and perfect smile now. I managed the midline. I managed the class 1. I managed the gummy smile. And I have very nice smile for her case. All this with aligners. How I reduced flaring, because TADS placed more distal, and aligner by itself hold the crowns better against flaring than wires, okay? Maybe this is my last case. before the time is finished. Also, we used accessories here. I have shift midline, I have class 2, I have problem like this, rotation of the molar. This is a very difficult procedure, crowding in the anterior, tats. So I have many problems. I have a long problem list. So we start the treatment plan. You can see 3 phases of the treatment, a lot of aligners, because the case is difficult, but we did manage to make the treatment. As you see, derotation of the molar with aligner, but it's somewhat difficult. In the second phase, even we added attachment palatally. We have now alignment of the teeth. I want to reach to the accessories, where we add class 2 elastics. You can see in the phase 2, we add class 2 elastics. I want to reach to the class 2 elastic. Look to the palatal button here. I added another palatal attachment with the treatment plan in order to facilitate movement. But even with that, I have some problem with the derotation. So what I did, I didn't add class 2. I remember why, because I have an implant, although this is good in order to add attachment, but I add an IZC with class 1 elastic. So as you see here, IZC for class 2 with class 1 elastic to precision cut. Then I added an alveolar TAD here on the ridge with a wire and an open coil spring to derotate the molar. This is a very predictable movement and will make my movement easy. And I cut, as you see, I cut from the aligner after the 5. So after a while, I have a complete derotation and the space is open. Now we make the rescan to finish our case, okay? No, sorry, this was the last case, and this is the case of the molar uprightening. And we will finish with this case where you can see an accessory of molar uprightening, where we upright the molar in order to retract with a TAD. And also on the lateral, I used an extrusion elastic because the lateral was, there was loss of tracking. On the other side, the patient wasn't that compliant, bad patient. So I used a lot of accessory, 2 extrusion elastics for the lateral, 1 uprightening for the molar. But we managed to finish everything with accessories, okay? So you can see improvement in the molar uprightening. Thank you. Sorry, I was somewhat fast, but I like to cover everything and show you everything. I hope it was useful. Thanks for the attendee. Thanks for organizing by Sagalign Lab, 3D Master guys. Thanks for you for this good organization, and I hope there will be more modules in the future.